Hello friends, I am Dr. Farheen, your OBGY faculty at Aakash PG Plus. Let's start the third innings of INICET 3030. The time starts now. First question is, sinusoidal pattern on CTG is seen in which condition? So before that, let's go through the normal CTG pattern. We can see this is the fetal heart rate. What is the baseline fetal heart rate? You just need to draw a line over here, and this is coming out to be 150 beats per minute, right? This is 150. The amount of zigzag pattern that you see, that is the variability, and it's a good thing. And these peaks that you are seeing, these are the accelerations, and that is also a good thing. So what do we mean by a sinusoidal pattern? Sinusoidal pattern, as you can see, that there are typical repeated waves like this, and there is no variability over here, there are no accelerations, right? So this is a pathognomonic sign of fetal anemia, and it will be present in all conditions which is leading to fetal anemia. So what are those conditions? A, vasa previa. Number 2, RH isoimmunization, and number 3, twin to twin transfusion. It is a very important question. So our answer here is vasa previa. For how long should the CTG tracing be stored in a case of an uneventful pregnancy when everything goes well? And for how long should it be stored in high risk cases? So it should be stored for 25 years if everything is fine. But in patients who are high risk cases, it should be stored lifelong. Another important thing, CTG is only reliable after 32 weeks of pregnancy. So question number 4, identify the feature which correctly describes the CTG trace. This was recently asked in INICET. So we have the CTG trace over here, but instead of acceleration, we can see that there are repeated dips like this. And this is the maternal contraction trace. And we can see clearly that the dip is starting when the contraction is ending. So the contraction is starting here. This is the peak of the contraction. The contraction starts to slow down here, and here is where the deceleration is starting. Coming to another point, in this CTG trace, we can see that this is the maternal contraction. This is the peak of the maternal contraction, right? And here, the dip in the fetal heart rate is totally corresponding to the peak of the maternal contraction. So it is in mirror image with the maternal contraction. Deceleration can be of 3 types. Early deceleration is a very important exam question, late deceleration, and variable deceleration. What do we mean by early? Early is when it's a mirror image of the uterine contraction. Late deceleration is that the deceleration starts after the contraction has peaked. So this is the maternal contraction has peaked, and deceleration is starting after the peak of the maternal contraction. Variable deceleration is that it does not have any normal pattern or regular pattern, and it can start or end anywhere. What is the significance of this? Early deceleration is seen in cases of head compression. So basically it's a normal thing. As the baby is coming down the vagina, the head gets compressed, and it is nothing to worry about. Late deceleration is seen in cases of uteroplacental insufficiency. That means that the placenta is not working that well. And variable deceleration is seen in cases of cord compression, that the cord is getting compressed somewhere, and this is also not a very good finding. So how do you remember this? The mnemonic for this is HUC, early, late, and variable deceleration. So coming back to the question, which correctly describes the CTG trace. Is it a late deceleration? Yes, it is a late deceleration. Is it a non-stress tracing? What is the difference between the NST and CTG? So CTG is nothing but NST done in labor. So what is labor doing? Labor is adding contractions to the fetal heart rate trace. It is putting the fetus in stress. Okay. So is it a non-stress tracing? No, it is a stress tracing, and it is CTG. Beat to beat variability is not normal. Nothing can be found out from this trace. Is it a sine wave pattern? No, it's not a sinusoidal pattern, right? So therefore, this is your answer. Which among the following is wrong about late decelerations? So are they smooth and gradual? Yes. They start after the uterine contraction starts and end after the uterine contraction? Yes, because they are not in mirror image. The fall in heart rate is by more than 30 to 40 beats per minute from baseline? No. So for all decelerations, any dip in fetal heart rate by more than equal to 15 beats per minute by more than equal to 15 seconds is the definition. Okay. It is not followed by acceleration. Well, it is not defined that way. So therefore, C is your option of choice. Now question number 6. Which of the following is not true about lupus nephritis in pregnancy? It is one of those questions when you don't know much about a rare disease, you can somehow come to the answer by exclusion. So let's go through the option. Option A, immunosuppression can be continued during pregnancy. Well, we have a question mark on this, we don't know. Pregnancy is to be planned once the disease has been silent for at least 6 months and there is no evidence of renal dysfunction. This somehow seems sensible, but I'm not sure about this, at least 6 months. So again, question mark. High dose steroid for lupus flare in pregnancy are safe. So for this, we need to know whether corticosteroid is safe in pregnancy or not. Okay. Ecosprin, methotrexate, cyclophosphamide, and azathioprine are safe in pregnancy. If we don't know much about anything, we at least know that methotrexate is definitely not safe in pregnancy, right? Because if it is given in ectopic pregnancy and molar pregnancy, we ask patient to conceive after 1 month or 1 year, right? Cyclophosphamide again is not safe in pregnancy. This also we know. So this is definitely the answer of choice by exclusion. So this is the FDA category of risk of drugs. Corticosteroid and azathioprine are some few drugs which can be given in pregnancy. However, the human risk cannot be ruled out. But what is totally contraindicated? Methotrexate and leflunomide are totally contraindicated in pregnancy. So therefore, this is our answer. Question number 7, Kasowitz rule is related to. Now this is totally a new and a rare question. Either you know it or you don't know it. Few questions are like that. So let's see what it is. Kasowitz rule say that if a woman with untreated syphilis has a series of pregnancy, untreated syphilis, okay, then the likelihood of infection of fetus in later pregnancy becomes less. What do we mean by this? So for example, in the first pregnancy, there is a miscarriage at 5 months. In the second pregnancy, what can happen that there can be a miscarriage in 7 months. In the third pregnancy, what can happen that the baby can continue to term, but it is a stillbirth baby. In the fourth pregnancy, what can happen that the baby is born alive, but it has congenital syphilis. And number 5 is that the baby is born alive also and it has no signs of infection, so baby is healthy. So this is what Kasowitz rules say, that with each successive pregnancy, the prognosis of the baby gets better. A few points about maternal syphilis. Routes of maternal syphilis transmission to fetus is by transplacental. It is the most common route. 50% is risk by this. Neonatal infection can occur during delivery. Maternal infection can lead to preterm delivery, IUGR and fetal infection. Newborns with infection can have petechiae, they can have lymphadenopathy, heart and lung involvement. So Kasowitz rule is related to congenital syphilis. Another important point about congenital syphilis is your Hutchinson triad. This has also come as an exam question. What is Hutchinson's triad? So it is presence of Hutchinson's teeth, interstitial keratitis and deafness of the 8th nerve. What is true about the cytomegalovirus infection? Let's go through the explanation first. Each and every point in this chart has been asked as a question, so please remember everything. Cytomegalovirus is the most common cause of congenital infection. Okay, so it is also a most common and the leading cause of sensory neural hearing loss. Second point, if the mother has a primary infection, which means she has been infected for the first time, then the risk that the baby is going to have congenital infection is 30 to 40%. If the mother has been previously affected and now she has been affected for the second time, which is a secondary infection, the risk for congenital infection is 1 to 2%. Now, only 10 to 15% of neonates will be symptomatic at birth, and only 10 to 15% of neonates who are asymptomatic at birth are going to present with sensory neural hearing loss later in the childhood. Alright. After the primary infection, what happens that the virus becomes latent in the body, and despite high level of IgG antibody, the patient can still continue to be infectious. Transmission of the virus to fetuses antenatally, how? By the transplacental route. It can be there during labor and delivery and also at the time of breastfeeding. Now there is a triad for cytomegalovirus infection. It can lead to jaundice, petechial rash and hepatosplenomegaly. So this is the clinical triad. So how do you come to the diagnosis of cytomegalovirus infection? This is also a very important exam point. If the mother is the diagnosed case of cytomegalovirus, we need to find out whether the baby is infected or not. How? So by amniotic fluid sampling. Amniocentesis is performed only after 20 weeks of gestation. If the amniocentesis confirms that yes, the baby has infection, then we will perform serial ultrasound of the baby every 2 to 3 weeks. Also, we will perform cerebral MRI of the infected baby around 28 to 32 weeks of gestation, because it tends to involve the brain also. So what is the treatment? Treatment is antiviral drugs, ganciclovir and valganciclovir. Congenital CMV should be confirmed at birth. So after the birth of the baby, within 3 weeks of life, it can be confirmed by taking urine or oral swab from the baby. If it comes out to be positive, then within the first month of life, antiviral treatment should be started. Coming back to the options, classical triad is hearing loss, hypoplastic enamel, calcification. No. The clinical triad is jaundice, petechial rash, hepatosplenomegaly. Hearing loss can appear later in life in asymptomatic babies. Yes, it can. 30 to 40% babies are symptomatic at birth. No. Only 10 to 15% were symptomatic, right? Babies born to mother with immunoglobulin G, CMV are immune to transplacental spread. No. Even if the mother has had secondary infection, she can definitely transmit the infection to the baby, right? A second gravida comes to antenatal OPD. Her son goes to school and he has contracted varicella. What is varicella? Varicella is chicken pox. Her blood test for varicella antibody is negative. What does this signify? Now she does not, so this is basically a common sense question. She does not have antibody against varicella, so what does this signify? It signifies that she is susceptible to the disease. Now, is she susceptible to chicken pox or is she susceptible to herpes zoster? We need to differentiate between these two. For that, we should know what is herpes zoster. So when the patient first gets the chicken pox infection, that is a primary infection and she gets chicken pox. After she gets cured with this infection can get stored in the neural system of the body and later on it can get reactivated and cause herpes zoster. Okay. So this is a reactivation of a chicken pox that the patient had prior. So coming back to the question, she will be susceptible to chicken pox, not herpes zoster, because herpes zoster is the latent infection of chicken pox which gets reactivated later. Question number 10, the same patient has come to OPD. Her son goes to school, has contracted varicella. She has never had chicken pox. How are you going to manage her? So the first question was that is she susceptible to chicken pox? Yes. But now since you know that she is susceptible, how are you going to manage her? Let's go through the explanation. So the pregnant woman comes with exposure within 10 days. What are you going to do? So first of all, you are going to ask her, has she been immunized? Immunized means, has she got this infection earlier or not? And the second thing, has she had any vaccination for chicken pox or not? Okay. So if the answer to both of them is yes, you need to just reassure the patient and do nothing. If the answer to this is no, then you are going to check the varicella IgG status in the patient. If the varicella IgG status in the patient is positive, that means she is immune and you just need to reassure her. But if the varicella IgG status in the patient is negative, then we have to give her varicella immunoglobulin. Very important point that this varicella immunoglobulin can be given in pregnancy and this is different from the varicella vaccine. Varicella vaccine is given only to those women who come to you preconceptionally. It is contraindicated in pregnancy. So once you give this injection to the patient, you ask her not to conceive for 3 months. Alright, so the answer is check her immunity status by varicella IgG. Give her varicella vaccine? No, because it is contraindicated in pregnancy. Start acyclovir? Not yet. Admit her? No need. Now the patient has presented with rash to us. What are we going to do? First of all, ask her, has she been exposed within 24 hours or not? If the answer to this is yes, then we will start acyclovir. If the answer to this is no, which means it has been over 24 hours, then you need not do anything, just reassure her and give her symptomatic treatment, which is painkillers. Acyclovir is generally prescribed after 20 weeks of pregnancy, but there is no contraindication if you prescribe it earlier. So, if she developed a rash 10 hours back, how will you manage her? Since this is within 24 hours, we can start acyclovir. If she has developed a rash 2 days back, so what are you going to do? You are going to do nothing but reassure her and give her symptomatic treatment. When is the maximum chance of varicella disease transmission? So the maximum chance of varicella disease transmission is when the mother develops rash within or after 7 days of giving birth to the baby. 1 out of 4 babies are going to get infected in this case and have neonatal varicella syndrome. And when is the baby going to get severely affected? Severely affected when the mother has got an infection at less than 28 weeks of period of gestation. It is known as fetal varicella syndrome. It is a typical triad that it is going to affect the limbs of the baby. There will be chorioretinitis and it can cause skin scarring also. Okay. So the maximum risk of disease transmission is before or after 7 days of birth. But when is the baby going to get severely affected? When the mother has infection before 28 weeks of period of gestation. Okay. So what are you going to do to the neonate? You can give the baby immunoglobulin and acyclovir. So when is the maximum chance? When the mother develops rash 7 days within or after giving birth. When is the maximum chance of fetal varicella syndrome? When the mother is affected before 28 weeks. A primary gravida at 36 weeks presents with painful vesicular lesions. She does not give history of similar lesion in the past, which means that it is a primary case. How are you going to manage her? So painful vesicular lesions point to herpes simplex. It is a DNA virus. It is sexually transmitted disease. If the patient has presented to us with this condition, we also need to screen her for HIV, syphilis and chancroid. Okay. So there are 2 types of HSV, HSV 1 and 2. HSV 1 generally affects the oral area and HSV 2 generally affects the genital area. The infection can be primary, that the mother is getting it for the first time, and in that case the risk of fetal transmission is very high, 40%. If the mother has gotten the infection for the second time or the third time, if it's a recurrent infection, then the risk of fetal transmission is very low. Few points about herpes simplex. This is how the painful blister looks like, and if it ruptures, then it ulcerates like this. Let's first discuss the treatment of primary herpes when the mother has gotten the infection for the first time and the risk of fetal transmission is 40%. So if the infection is less than 28 weeks, we will give her acyclovir 400 milligram thrice a day for 5 days, okay, and restart it again from 36 weeks till delivery because the fetal transmission is really very high and we need to protect the baby. The patient here can deliver vaginally because by this time the mother would have developed some immunity. But if the patient has developed this primary infection after 28 weeks, we will put her in acyclovir till delivery. We are not going to stop it and will deliver the patient only by cesarean section. Vaginal delivery is contraindicated. In recurrent herpes, the fetal transmission was really low. It was 0.4%. So what are we going to do? We will give her 400 milligrams of acyclovir from 36 weeks onwards till delivery and the patient can deliver vaginally. So going through the options, acyclovir and vaginal delivery, no, because it's a primary infection. Analgesics and antibiotic, no. Antiviral and induction of labor, no point in induction of labor vaginal delivery because it is contraindicated and we have to go for elective cesarean section. Which of the following is false regarding the management of diabetes in pregnancy? Okay, so let's go through the salient features first. In diabetes, if there is a macrosomic baby more than 4.5 kg, what do we have to look for? Shoulder dystocia. So will you go for a cesarean section or not? There are two very sharp guidelines for this. If the mother is diabetic and she has a macrosomic baby, cesarean section is preferred and you will go ahead with that. But if the baby is just macrosomic, more than 4.5 kg, and the mother is not diabetic, right? Neither overt diabetes or gestational diabetes, you will go ahead with the vaginal delivery, okay? So only when the baby is more than 4.5 kg and the mother is diabetic, both these conditions, then only you will go for a cesarean section. How do you manage diabetes in pregnancy? This is also a very important exam point. Start folic acid 4 milligram till 13 weeks. It is not 4 microgram, it is 4 milligram till 13 weeks. Aim for the fasting blood sugar to be less than 95, 1 hour postprandial less than 140, 2 hours less than 120. HbA1c is kept at less than 6%. If the HbA1c is more than 10%, then there is very high risk of congenital malformations. Now measure HbA1c in the first trimester. You also measure the renal function test, retinal scan, and again this retinal scan is repeated 28 weeks. The patient will be seen every 2 weekly between the obstetrician and the endocrinologist. And the BP has to be measured at every visit. Why? Because there is 2 times increased risk of preeclampsia. What is the intrapartum management? If she is a gestational diabetes, which means that she has developed diabetes in the pregnancy, you will deliver her by 40 weeks, 6 days because the complication is going to be lesser. But if the patient is a known case of diabetes type 1 or type 2, then you will induce her or do cesarean section by 37 to 38 weeks of period of gestation. Throughout delivery, you have to monitor the patient's blood sugar levels and it is kept at 80 to 140 milligram per deciliter. So if the patient is on insulin and you are going to induce the patient, the night dose of intermediate insulin is planned, but the morning dose is going to be withheld. If the patient is in active labor, we have to maintain the blood sugar between 80 to 140, right? So if it goes less than 70, then we will start with dextrose. Coming back to the question, what is false? In a patient being planned for induction of labor, the night dose is given as planned and the morning dose is withheld. Yes. RBS is maintained between 80 to 140. Yes. Blood sugar monitoring levels, fasting is kept at 95, 1 hour at 140, 2 hours at 120. Yes. Elective cesarean section has no role in reducing the incidence of brachial plexus injury. Now, brachial plexus injury is seen in which case? In shoulder dystocia. So, if the baby is macrosomic and the mother is diabetic, then we go for elective cesarean section and therefore this option is wrong. All are criteria of overt diabetes in pregnancy. What do we mean by overt diabetes? That the patient was having diabetes before she got pregnant. So, this is the criteria: RBS more than 200, HbA1c more than 6.5, fasting blood sugar more than 126. This is also your medicine question and they have been asking this repeatedly. You just need to mug up these values. There are no two ways about it. So this is our answer. As per DIPSI, patient is said to have gestational diabetes at what random blood sugar value? So the screening of diabetes is done by 2 methods. One-step approach, which is DIPSI and WHO, and 2-step approach, which is by ACOG. So in ACOG approach, what we were doing? We were doing GCT, and on GCT, if the blood sugar level was coming out to be high, then we were going for oral glucose tolerance test. So this was a really hectic and a long procedure. DIPSI came out with a method where we give patient 75 grams of glucose irrespective of the fasting status. The patient is not supposed to fast in this, and we take a single sample after 2 hours. Okay, so if the sample after 2 hours is less than 120, we need not worry. If it is more than 140, then it is a case of gestational diabetes. If it is more than 200, then it's a case of overt diabetes which had not been maybe diagnosed earlier. As per the DIPSI value, the patient is said to be diabetic if the RBS is more than 140. What is the most specific? The question over here is what is the most specific, not most common. Most specific congenital malformation seen in babies with diabetic females. So first of all, the most common system which is involved is the cardiovascular system. The most common anomaly is the ventricular septal defect, and the most specific here is TGA. Okay. The second most common system which is involved is the central nervous system. Here the most common anomaly is anencephaly of spina bifida, and the most specific is caudal regression syndrome or sacral agenesis. If they were to ask what is the overall most specific, then overall also most specific is your caudal regression syndrome. So coming back to the question, this is going to be your option. A second gravid at 36 weeks presents to OPD with blood pressure 150 by 105. Okay. Urine dipstick 3+, which means she is preeclamptic. All are symptoms of imminent eclampsia except. So let's go through the explanation first. The signs of end organ damage or imminent eclampsia are the same. So don't get confused in between this. It's very simple. Thrombocytopenia, platelet count less than 1 lakh. You just need to remember this entire table. Renal insufficiency when the creatinine level is more than 1.1 or doubling of the baseline. They have asked each and every point from the table. Liver involvement where the serum transaminase level is twice the normal. Also there is epigastric pain. Cerebral symptoms, headache, blurring of vision, convulsions, hyperreflexia, and pulmonary edema. Also a few important points on hypertension in pregnancy. So what is gestational hypertension? When the blood pressure is more than equal to 140 by 90 millimeters of mercury on 2 occasions 4 hours apart after 20 weeks of pregnancy, and it resolves by 12 weeks postpartum. So if the blood pressure has been high before 20 weeks of pregnancy and it is not resolving even 12 weeks after postpartum, it will not be gestational hypertension. Okay. What is preeclampsia? Preeclampsia is nothing but gestational hypertension plus presence of protein in urine. Okay. What is eclampsia? Eclampsia is a patient with preeclampsia plus seizures. What is chronic hypertension? That the patient has increased blood pressure before 20 weeks of pregnancy and it is not getting resolved even after 12 weeks postpartum. And what is chronic hypertension plus preeclampsia? So remember one thing, that preeclampsia is hypertension with protein in urine. So the patient will have protein in urine and signs of end organ damage will be there, but the patient will be having raised blood pressure even before 20 weeks of pregnancy. So coming back to the question, again it's an answer of exclusion. Will the patient have headache? Yes. Blurring of vision? Yes. Persistent epigastric pain? Yes. Fetal edema? Well, this is a physiological sign of pregnancy. So this is also a very common sense question and this is going to be the answer. Which of the following is false regarding magnesium sulfate? Let's go through the explanation first. So magnesium sulfate was given as a MAGPIE trial and the mechanism of action is that it has a central inhibitory effect. You need to remember these things. It inhibits glutamate and it activates adenosine and it blocks the NMDA receptors. Okay, these are some fancy names but you just need to mug these up. And it decreases motor end plate sensitivity to acetylcholine. In addition to this, it is a vasodilator, it blocks the calcium channel and therefore it cannot be given along with other calcium channel blockers, okay, like nifedipine. It increases the blood flow to the brain, uterus and kidney since it's a vasodilator. It is also a mild tocolytic. So let's go through the options, which is false. Magnesium sulfate causes uterine relaxation. Yes, it is a tocolytic. It is continued up to 24 hours after delivery or last attack of seizure. Yes. In renal failure, the loading dose has to be adjusted. We are aware that it affects the kidney and we need to adjust the dose. Yes. It has excitatory effect on cerebral cortex. No, it has inhibitory effect. What is the first sign of magnesium toxicity? This is a very straightforward question. The therapeutic level of magnesium sulfate is 4 to 7 milliequivalents per liter. You need to remember this. And the first thing which goes is the knee jerk or the patellar reflex when the magnesium levels reach 10 milliequivalents per liter. Respiratory depression follows that, followed by the cardiac arrest. What is the contraindication of magnesium sulfate? So the contraindication is myasthenia gravis and deranged renal function. What is the antidote for magnesium toxicity? Antidote is 10 milligram injection of 10% calcium gluconate or calcium chloride. So the first sign of magnesium toxicity is loss of knee jerk. Now next question, which of the following does not fit into the theories of causation of preeclampsia? Well, this looks like a very scary question, lot of text is here. So even if you don't know it, let's try to solve it by a general knowledge. So prostaglandins play an important role. Thromboxane A2 decreases. First of all, in preeclampsia, all of us know that there is vasospasm, which means that the artery is constricting. Okay. So thromboxane A2, all of us know, is a vasoconstrictor. It should ideally be increasing. Here it says that it decreases. So this raises a query in my mind. Endothelial cell dysfunction leads to reduced nitric oxide level and it causes preeclampsia. Well, nitric oxide is what? A vasodilator. So the level is reducing. Yes, the level can reduce in preeclampsia. It seems right. Vasoconstriction can lead to ischemia, necrosis, hemorrhage, end organ damage. Yes, end organ damage is seen in preeclampsia and can lead to ischemia. This also seems fine. Anti-angiogenic factors play an important role. There can be increase in SFLT1 and PGF, decrease in PGF. Well, these are again few fancy names. I have doubt about these. I don't know whether what increases or what decreases. But I'm very sure that thromboxane A2 should be increasing, right? Because it's a vasoconstrictor. So my guess will be option number A. Let's go through the solution. In normal pregnancy, what happens that the vasodilator effects predominates the vasoconstrictor effect. What are the vasodilators? Nitric oxide, prostaglandin, and VEGF. Okay, vascular endothelial growth factor. All growth factors are generally vasodilators. What is vasoconstrictor? Angiotensin 2 is a vasoconstrictor. Now in preeclampsia, two things are happening. What is the main pathogenesis? Vasospasm and endothelial injury. So I have simplified this all in one chart. Endothelial injury can be because of oxidative stress, all your lipid peroxide, superoxide radicals, TNF alpha, cytokines, IL-6. We know that interleukins and cytokines, they lead to endothelial injury. Vasospasm, where the vasoconstrictor effects predominates. So what were the vasoconstrictors? Angiotensin 2, SFLT1, endoglin 1 is also vasoconstrictor. Thromboxane A2 and endothelin is also vasoconstrictor. Nitric oxide, prostaglandin, and VEGF, they are vasodilators. So if you're not able to remember the fancy names of vasoconstrictor, just remember these things, that only the vasodilators are nitric oxide, prostaglandin, and vascular endothelial growth factor. So therefore, this is going to be our answer. A patient who is 35 plus 5 weeks presents with complaints of altered sensorium, which means that the brain is getting affected somewhere. Blood pressure is 170 by 110. So what was the blood pressure for gestational hypertension? More than 140 by 100 mmHg, right? On 2 occasions, 4 hours apart. 3 plus proteinuria, which means it's a preeclampsia. Wherever there is proteinuria by more than 1 plus, it's preeclampsia. She is 3 centimeter dilated, 50-60% effaced. What will be your next step? We can see that she has progressed in her labor also. So let's go through the solution. The main principle in management, I have simplified it. You just need to remember this thing, that if the diastolic blood pressure is more than 100 or the systolic is more than 150, you need to start antihypertensive. So if the blood pressure is 150 by 80, suppose, you will start antihypertensive? Yes. If the blood pressure is 130 by 100 mmHg diastolic, will you start? Yes. If the blood pressure is more than 160 by 110 or the proteinuria starts coming, which means all patients of preeclampsia, you will admit them in the hospital. Now, whichever gestation you are going to admit them, because we need to carry out certain investigations. Okay. And in all signs of impending eclampsia, you are going to start magnesium sulfate. So basically, this is the crux of management of hypertension in pregnancy. Another important point, time of delivery. If the patient has gestational hypertension, we can take her to 37 weeks. But if she is preeclamptic, which means proteinuria 1 plus gestational hypertension, we will deliver her between 34 to 36 plus 6 weeks. So coming back to the question, the patient is having 3 plus proteinuria. In preeclampsia, what is the definition? 1 plus proteinuria. But here she is having 3 plus, which means she is a severe case. Also, the blood pressure is 170 by 110, which is severe preeclampsia. And when do we deliver them? Between 34 to 36 plus 6. She is 35 plus 5. So ideally, we have to terminate her pregnancy and we have to deliver her. Will you do conservative management? No. Tocolytic, why? No, not needed. Steroid, again not needed. She is 35 plus 5 weeks. Magnesium sulfate, management of hypertension, termination of pregnancy, yes. So therefore, this is the option of choice. Question number 24. As per Anemia Mukt Bharat program, what is the dose of elemental iron folic acid? So the elemental iron is 60 milligram, folic acid is 500 mcg. It is to be given for 180 days, including antenatal and the postpartum period. So this is your option of choice. A patient has been diagnosed with mild anemia at 35 weeks. How are you going to manage her? So first of all, what is the definition of anemia? There are two definitions as per WHO and as per the CDC criteria. WHO says any hemoglobin less than 11 gram percent or hematocrit less than 33%. CDC has further explained it elaborately. First trimester hemoglobin less than 11 gram. Second, third less than 10.5 and postpartum less than 10 is anemia. Talking about the severity of anemia, mild anemia is when the hemoglobin is less than 11. Moderate is between 7 to 10. Severe is when the hemoglobin goes less than 7. Very severe is when it goes less than 4. How are you going to manage these patients? So in a patient with very severe anemia, we will go ahead with blood transfusion where hemoglobin is less than 4. In severe anemia, hemoglobin less than 7, we will go for parenteral iron. But when it is mild to moderate anemia, we have two options, 2 tablets of iron folic acid or parenteral iron. So how are you going to decide what are you going to give? First of all, when we start the treatment, it takes 3 weeks minimum for the hemoglobin to rise. So we should know that we should be having 3 weeks in our hand. What are the similarities between the oral and parenteral iron? The similarity between them is that both of them take 3 weeks for the rise in hemoglobin, even if you are going to give IV iron. Remember that. And the difference is that patients can be intolerant to this oral iron, or they can have side effects. Okay, so it is very important to know the period of gestation of the patient for two things, that it will take 3 weeks for the hemoglobin to rise. Also, if she is intolerant to oral iron, you have sufficient time to shift her to parenteral iron. So going back to the question, the patient is 35 weeks period of gestation. She has mild anemia. So what are the options which are available? We can either give her oral or we can give her parenteral. How much time is it going to take for the hemoglobin to rise? It will take 3 weeks. After 3 weeks, she's going to be 38 weeks. She can also go in preterm labor. Would you want to wait for that long? No. So therefore, the option of choice here is iron ferric carboxy maltose. All are true about cardiac changes in pregnancy, except the cardiac output starts rising from 5 weeks onwards. In the antenatal period, it is maximum at 28 to 32 weeks. They have asked this as a question. During labor, in addition to this, there is further 50% increase. And immediately intrapartum, there is 80% increase in the cardiac output. This cardiac output remains high for 1 to 2 days after giving birth, and it will return to normal within 10 days. Alright, so this is all you need to know about cardiac changes in pregnancy. So when is the cardiac output maximum? Immediately postpartum. If this is not in the option, then during labor. If this is not in the option, then antenatally 28 to 32 weeks. They can also ask when is the cardiac output maximum antenatally directly. So the answer will be 28 to 32 weeks. Few other points. Cardiac output increases by 40 to 50%. What is cardiac output? Your stroke volume into heart rate. So since this is increasing by 50%, stroke volume and heart rate is also increasing by 30 to 25%. Only blood pressure decreases. What are the signs of heart disease in pregnancy? Cardiomegaly. All diastolic murmurs are pathological, remember this. All ejection systolic murmur more than grade 3. Persistent splitting of S2, presence of S4, and increased JVP, cyanosis and clubbing. But all these physiologies cannot be explained in 30 minutes, so please go through my YouTube videos on heart disease in pregnancy. So coming back to the question, cardiac output is maximum at 32 weeks? Yes. S3 is physiological? Yes. ECG shows left axis deviation? True. Cardiac output is maximum at the time of delivery? No. Cardiac output is maximum postpartum. Pregnancy is contraindicated in all except. Okay. So it's a very simple mnemonic that I have made. The mnemonic of this is NOPES. If NOPES is present, then the mortality is 25 to 50%. What is NOPES? NYHA class 3, class 4. Obstructive lesions of the left side of the heart, which is going to decrease the cardiac output. So mitral stenosis or aortic stenosis, that too if it is grade 3 and grade 4. P is your conditions which cause pulmonary hypertension. There are only two conditions, coarctation of aorta and Eisenmenger's syndrome. E is for your ejection fraction less than 30%. S is your Marfan syndrome with aortic root dilatation, this is very important, more than 4 centimeter. Okay. So lesions in which pregnancy is contraindicated, NOPES. Lesion in which MTP is advisable, NOPES, and the termination should be done within 12 weeks of period of gestation. What are the predictors of adverse outcome of pregnancy? If they were to ask, then it is NOPES plus history of peripartum cardiomyopathy. Okay. So pregnancy is contraindicated in all except ejection fraction 50%. What is the best method of contraception in heart disease patients? So the best method of contraception is IUCD. Second best method is your barrier contraception. Progesterone only pills or parenteral progesterones are safe, but they can cause irregular spotting and bleeding here and there, especially if the patient is anticoagulated. But what is contraindicated in heart disease patients? Steroidal contraception, because it can lead to thromboembolic phenomena. In permanent sterilization, vasectomy is preferred over tubectomy. Best time for tubectomy is 6 weeks postpartum. Second best time is 1 week postpartum, and it is done by laparotomy, not laparoscopy. All are correct about peripartum cardiomyopathy except. So let's go through a solution first. What is peripartum cardiomyopathy? When there is cardiac failure within last month of pregnancy, within last month, or within 5 months postpartum. Okay. So suppose she has delivered here in this 1 month prior to delivery and 5 months postpartum. There is no cause for failure. There is absence of any previous heart disease, and there is left ventricular dysfunction. How are you going to assess that? Ejection fraction less than 45% and left ventricular end diastolic length more than 2.7 centimeter per meter square. You just need to remember these values. How are you going to treat these patients? Treatment is A, B, C, D, E, and the mortality is high. Mortality is as high as 20 to 50%, and the recurrence is also as high as 20 to 50%. So coming back to the option, ejection fraction less than 45%, yes. Cardiac failure within last month or within 5 months, yes. Absence of any previous heart disease, yes. Mortality is 90%, no, it is 20 to 50%. The question can also be asked as, which heart disease is worst tolerated, which has the highest mortality risk, in which is pregnancy contraindicated, termination of pregnancy is advisable. So the highest mortality is seen in Eisenmenger's syndrome. Alright. So in NOPES also, your Eisenmenger's has the worst prognosis. Well, this brings us to the end of the innings. See you in the next match. Thank you.